Okay. Yes, as I told you, you can see these presentations on the web later. So this presentation is mm, with a different perspective from the one that you have seen before. Before we discussed new possible antidepressant treatments, this goes a little bit in deep on an issue that a few years ago was not very considered. Is a new thing, and there is a much interest on this topic at present. I will go through, this is Bologna, I will go through all the different point of view of insulin resistance, metabolic syndrome, depression, treatments, and so on. Let's start from the beginning. It has been said more than 100 years ago that man is what he eats, and the importance of food is really rising in the recent years. Let's discuss a little bit how and which are the evidence that can support this. Not working? Okay. First, in a series of papers, we have recently described the point that dysregulated insulin signaling is extremely relevant in mood disorders, but not only in depression, probably also in bipolar disorder and in many other psychiatric disorders. Let's discuss why. First, from animal studies, we have a very strong evidence that insulin is important for mood. The most simple study is to make a knockout, take out the insulin receptor in the brain of the mice, and the result is that mice show a depressive-like behavior. So if you take away insulin from the brain of the animal behaves in a depressed way. The first and very important point. Second point, if you manipulate a down-regulation of the insulin receptors in hypothalamus, hippocampus, you know that hypothalamus, hippocampus are relevant for mood disorders, you create again a depressive and anxiety-like behavior. And on the opposite, we have seen also that both depression and cognitive symptoms are associated with reduced growth factor in the elderly that are somehow related to this system as well. This is why in the recent paper and many others, we are focusing on the relation between type 2 diabetes and mood disorders. Probably you are all aware that insulin resistance is a mechanism that means that the insulin that the pancreas is producing regularly is no more active because the receptors do not translate properly the signal from insulin. So it is like insulin is not working anymore. This is usually linked to genetic predisposition, but many environmental factors, obesity and so on, food is very important. And when insulin resistance goes up, at first the individual increases the insulin production, but at a certain point it's not possible anymore. And therefore, patients develop the type 2 diabetes that needs, of course, specific treatment per os that is different from type 1 diabetes. The interesting point is that how this can be linked to mood disorder. This is a metabolic disorder. Well, it is a metabolic disorder, but as we will see later, I anticipate here one point. The problem is that insulin is not only useful for storage of sugars or of glucose, is useful for health of brain, muscles, and so on. When you have insulin resistance, you have a damage of many organs. And this is why it's not surprising that is in this very large cohort study, you see that there is a very strong effect of brain disorder that leads to type 2 diabetes, and also the opposite, type 2 diabetes that can lead to brain disorder. So this is the starting point because this is just epidemiologic. This is just observational. When how many times you see a patient that has a type 2 diabetes and develops psychiatric disorder, or how many times you have a patient with a psychiatric disorder that develops type 2 diabetes. Just observation. In the following part of the presentation, we will see why and how we can manage this problem. In any case, the odds ratio from these very large epidemiological studies is relevant, is significant, of course, and is relevant, is about 2, except for anorexia, that, of course, is a different disorder. For depression and bipolar disorder, results are quite clear. One question that I usually receive when I talk about this topic is that, well, but metabolic disorders in depression and in schizophrenia are not biologically linked, are just a consequence. Some people say depressed people, they stay at home all day. Schizophrenics, they maybe usually don't do much activity and therefore they develop metabolic syndrome. Other people tells me, well, many psychiatric treatments induce weight gain. So we have a iatrogenic effect of psychiatric treatments and metabolic disorder. The answer is not so clear because there is strong evidence, I will show you later, that metabolic aspects, that diabetes type 2, insulin resistance, and mood disorders, schizophrenia, psychiatric disorders are related independent from environmental aspects or treatments. So is not a consequence of only a consequence of the sedentary lifestyles, poor sleep, smoking, or our psychotropic medications. Is also independent. Why? I told you before that insulin is useful for absorbing the sugars from blood to the organs, liver, muscles, and brain. Usually, this works very well. If you have insulin resistance, those organs do not receive anymore the glucose and the sugar, the energy that they need. So insulin resistance creates a dearth, a lack of energy where the energy is needed, muscles, brain, and so on. And what is negative is that the creation of fat, the fat cells, they are not affected by insulin resistance. So when you have insulin resistance, you have higher blood in your liver, but this higher glucose, higher sugar in your blood level, but this high sugar is not useful because cannot be used by brain or muscles. It is used only by fat tissues, and therefore it's a vicious circle. Patients get fatter and fatter and fatter and still are suffering from lack of sugar and energy where it would be needed. And therefore this is the vicious circle. As the chairman said, insulin is also in the brain because some people say, well, what's the point? We are talking about metabolic peripheric issues. No, 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 no. We are talking about the brain because insulin is also in the brain, is produced in the brain, is effective in the brain, and there are clear demonstrations about that. And in the brain, insulin is doing a lot of things. First is inhibiting the death of cells, is modulating, reducing neuroinflammation, is improving synaptic plasticity, and is modulating also neurotransmission. So insulin is doing a lot of things in the brain. And if you don't have insulin, or you have insulin resistance, the brain is suffering. How is suffering? Because, for example, dopamine is modulated by insulin. So lack of insulin in the brain that is due to insulin resistance leads to a reduced dopamine pathway functioning in a very complex way, by the way, but it modulates the dopamine pathway in a negative way, leading to lack of energy, apathy, anhedonia, and mood symptoms. Not only, insulin resistance also modulates in a negative way cortisol. And we know that cortisol, when abnormal, is a negative factor for mood disorders and the risk of depression. Inflammation, gut microbiota, as we discussed before, and the neurotransmission. And following this hypothesis, we very recently did this very large study with collaborators from Netherlands and other countries as well, Denmark. In the large sample of UK Biobank, trying to answer to this question, what happens when you have insulin resistance on your cognitive functioning? And the results were very clear. When you have insulin resistance, well, not all, but many of the cognitive domains are impaired. And this impairment is largely independent of the confounders. Slower processing speed and other numerical reasoning abilities, verbal abilities were all impaired. Why? Probably for the mechanism that I told you before, because there is a reduction on the connectivity in the brain because there is an increase of inflammation, all the negative aspects that we discussed. There is also evidence from genetic studies. You know that I work also in genetics. Genetics is important for bipolar disorder and mood disorder, but it's important also for metabolic syndrome and diabetes, more or less at the same level. Therefore, we studied if there is some kind of interaction between the two. And indeed, we were very surprised to see that the interaction is indeed there. There is a technique called Mendelian randomization that is used to see if the patients that have, for example, major depression lead to diabetes type 2. And indeed, there are studies supporting a causal effect of depression on diabetes type 2. It's not clear if there is another effect on the other direction from diabetes type 2 to major depression, as we have seen in the epidemiological studies. From a genetic studies, one is confirmed, one is less confirmed, but still they go in the same direction. In this other paper that has been published last year, we focused on another interesting point. Okay, we understood that insulin resistance and metabolic dysfunctions are important in psychiatric disorders. But which psychiatric disorders are more affected? And the results are very interesting because, and the color, I will tell you what they mean. First, the first cluster is that there is a positive genetic correlation. It means that the risk goes in the same direction for major depression and ADHD. So the major depression and ADHD have the same convergent risk factors of insulin resistance and metabolic problems. There is another cluster that goes in the opposite direction. That is obsessive compulsive disorder, anorexia, and schizophrenia is in between. This is not surprising. We know that obsessive compulsive and anorexia people, also from a clinical point of view, they are not very frequently in the metabolic state of abnormalities. And so the genetic finding confirm that the genetic for metabolic disorder is associated with mood and ADHD and not with OCD and anxiety, with the other disorders having no relationship. So which are the take-home message for this part? Insulin signaling is very relevant to brain functioning. Insulin is involved in cognition and hedonic perception. Mood disorders share genetics with insulin resistance. Share. So the liability is the same. This is very important. And the shared genes that we are working on could be the target of future treatment. From a clinical point of view, we were thinking with Giuseppe, but given that we have this large population data, let's see if insulin resistance and metabolic syndrome, they modulate the outcome of, for example, depression. Which is the outcome of these people? Do they have a better depression, a worse depression? They respond better to antidepressant, worse to antidepressant? What happens in the long term? And the results are very interesting. This is what we have done, and the results are exactly as we expected. Individuals with insulin resistance have more antidepressant treatment, more chronicity, more depressive symptoms, and worse treatment outcomes. This is demonstrated in a very, very large population. And this is a real-world confirmation that the basic studies that we had are indeed true. And many other details you can see in the paper. We don't have much time to discuss them today. Another recent paper that we have done with Siegfried Kasper, that was here, by the way, in a presentation yesterday, we've seen that, again, if we look at the BMI, that is an indicator, body mass index, an indicator of the metabolic status, it is indeed associated with treatment resistance, at least partially in a small sample, but is associated with a worse depression, with higher suicidality, earlier age of onset, and more comorbid disorders. So a worse kind of depression. This is a completely different population and a completely different analysis. In this other very large review that will appear soon on neuroscience and biobehavioral reviews, Chiara Presidente made a very extensive analysis of what is the connection between type 2 diabetes and mood disorders. The main take-home message, looking at a very large amount of literature, is that indeed the link between the two is a worse chronicity of depression, worse depressive symptoms, higher mortality, higher suicide risk, and reduced cognitive functioning. That is the same thing that we have demonstrated in the paper that I showed you 10 minutes ago. Okay, the last point that I wanted to show you is the treatment. Given at this point that we have clear that insulin resistance, that is mainly modulated by environmental factors like lifestyle, lack of exercise and food, insulin resistance that leads to type 2 diabetes is a negative mechanism in terms of inflammation, in terms of availability of energy for the tissues, and is negative in terms of worse depression, worse outcome of depression, and is also linked to bipolar, probably worse outcome, even if there are less studies. So the question is, what can we do? Antidepressants have a complex effect on this. Because you are well aware, we published a paper more than about 15 years ago, that we know that antidepressants, some of them can increase weight. So here we are in a difficult situation because antidepressant can worsen in some cases the metabolic status, but can also improve the metabolic status because being antidepressants, the patients are more active. So what should we do? Well, long-term treatment with some antidepressants indeed is increasing the BMI. We already demonstrated that. But lithium, we will talk later, but they are not the same. Some antidepressants are different from others. If you remember from our paper of 15 years ago, amitriptyline, mirtazapine, paroxetine may have an increased weight gain. Other, like escitalopram, agomelatine, or particularly bupropion, have a less effect on weight gain. So this is to say it's extremely important, I always say in all my presentation, to personalize treatment. Some antidepressant can have a benefit on insulin resistance, at least in the short term, or weight gain. Others less. It's important to prescribe the right one to the right patient. We went quick on lithium. It is interesting that lithium seems to have a protective effect in terms of insulin resistance, to the point that some people suggest to use insulin resistance as a possible marker of lithium response, but this is something that is not yet in the clinic. Other antidepressants that can be useful in this case are, for example, vortioxetine. Vortioxetine is one of current antidepressants with bupropion that does not give usually weight gain, usually gives also some kind of weight loss. And it has been demonstrated to have a very relevant benefit in terms of hypoglycemic effect. Tricyclics, of course, less. Already we discussed this. The last point I wanted to present you is the opposite. Okay, that some antidepressants can be useful for insulin resistance and some less. What the opposite? Are anti-diabetic treatment potentially useful for depression or not? Well, maybe the answer is maybe. Antidiabetic cross the blood-brain barrier, so they go into the brain, and there are some evidence of possible efficacy. For example, if you administer insulin intranasally, it seems that there are some potential benefits in terms of mood, memory, but still they're under studies, so we don't have clear evidence so far. So don't go home and administer insulin as an antidepressant because it has not been validated yet. Probably in the future will be. More interesting is metformin. Probably you are familiar with metformin is used for type 2 diabetes. Probably you prescribe a lot. Metformin is being currently studied as a potential benefit on many other disorders, including mood disorders, and improvement in cognition, improvement in anxiety. So metformin is very interesting as a potential compound that is beneficial on type 2 diabetes and depression. Also, some of the more recent anti-diabetics are potentially useful, but I will not go into detail here. Take-home message from this last point. Current evidence is not sufficient to recommend specific antidiabetics as antidepressants. However, some of the antidiabetics have some effect on mood and cognition. Pioglitazone and liraglutide are probably promising together with metformin. Of course, we need further research on that. So the conclusion of this presentation, I think you are very tired at the end of the day. conclusions are that patients with mood disorders should be screened for insulin-resistant condition. That means, the usual glucose blood test, BMI, hypertension, the usual medical evaluation. Pre-existing obesity may indicate the need for an alternative treatment because we should avoid those psychotropic drugs that can worsen the metabolic status that will be detrimental also for the mood treatment. Of course, healthy lifestyle is important. Check always the laboratory analysis of our patients and suggest as much as possible physical exercise 2-3 times a week. I saw that in many countries they are also like the previous presentation by bundle of they are developing this kind of remote physical exercise programs, telemedicine 2-3 times a week can be useful. Mediterranean diet, you in your country, I think you have already Mediterranean diet. Prebiotics, like we discussed before, can reverse maybe the metabolic damages and insulin resistance. Of course, there are a lot of studies that still needs to be done to understand the confounding variables, how much is due to the genetic, how much is due to the lifestyle, to the food, to the microbiome, to the treatments, to the mood. So it's a very complex clinical situation, but of course will be studied. In any case, mood disorders share genetics and etiological mechanisms with insulin resistance related diseases. This is the final point on which there are no doubts. There is an urgent need to consider metabolic aspects in mood disorders given the possible impact on treatment outcomes and prognosis. And it's possible with this kind of studies to identify new target for new treatments or repurposing of old drugs for a possible new treatment. Thank you for your attention and thank you to my collaborators, in particularly what I presented you today has been done by Giuseppe Panelli. Thank you.